Hi, Crystal Gentle here, wrapping up week number 2 at Empire, and I'd like to discuss what I've been learning. So last week we talked about the layers of shoulder anatomy, and this week I've sort of discovered that there are many layers to shoulder education as well, so it's probably best we stick right where we left off on the shoulder. So let's talk about shoulder pathology today. What is shoulder pathology? Well, it's the science behind the cause and effect of disease in the shoulder or issue in the shoulder. Think about that root word, path. We want to know the path to an issue so we can get the path back from the issue or the repair. Now the shoulder has 3 very common issues: rotator cuff tears, impingement, and instability. Let's discuss those. Cuff tears. Rotator cuff, it's in charge of the motion of your shoulder. So a lot of times a patient will come in with pain in their shoulder, weakness in their shoulder, or the inability to abduct their shoulder. And a doctor might diagnose this and give you a classification of either a partial or full thickness tear, depending on the severity. Now, last week you may remember we talked about the rotator cuff has 4 tendons: subscapularis, supraspinatus, infraspinatus, teres minor. Well, generally speaking, when we're talking about cuff tears, it's either in the supraspinatus or the infraspinatus. Now, a lot of people will say that no 2 shoulders look alike. Well, no 2 tears look alike either, but there are 5 basic patterns that we can learn to help us think about what we're viewing. Let me give you an idea. There's a crescent-shaped pattern that would be at the edge of the tendon where it meets the greater tuberosity. Crescent shape. There's also a U shape, which is like the crescent, but retracted further back medially on the shoulder. There's also a vertical shape, an L shape or reverse L shape, and then there's an inner substance tear. Now, repairs can work very differently depending on the type of tear you have. For instance, an inner substance tear that's up medially on the shoulder, a doctor might just need to stitch that up with some sutures. Whereas other tears, like a U-shaped tear, is torn off the footprint and needs to be returned. Now, what's the footprint? The footprint is where the tendon is supposed to be. Think about your footprint in the sand. If you're looking at your footprint, that's where your foot just was. We want to put the tendon where it just was. So in that type of repair, what we would need to do is use some anchors, surgical anchors, put it in the greater tuberosity, right here, and then use sutures that are loaded in the anchors to tie the tendon back down onto the footprint and to the greater tuberosity on the footprint, where it belongs. So that's kind of the basic idea behind tears and repairs. But you got to also remember that some tears are bigger than others, so they'll require more anchors. Some are single row repairs, other are double rows, where you'll have a lateral row of anchors and a medial row of anchors. So it can get pretty complicated, but that's the basics and all we need to know for now. Let's move on to impingement. When we're talking impingement, we're talking subacromial space. Let's get down to our definitions. Subacromial space. It's the space between your acromion and the rotator cuff. Also, we could look at the word, think about it logically. Sub meaning below, acromion, so we're looking at the space beneath the acromion. While we're on definitions, impingement we know means encroachment, impinging. So when we're talking about impingement, we're talking about encroaching on the subacromial space. And this happens in one of a few ways. The acromion can either have a bone spur, a bony growth on the undersurface of the acromion that is cutting into that area that the shoulder needs to move, or the acromion could be hooked from birth and naturally kind of move down into that space. And as you can imagine, if that space is compromised, it can cause irritation in the shoulder. Another problem in the subacromial space and can cause some discomfort up there could be bursitis. Now, bursa is generally a good thing. It's used as a lubricant, so it takes away the friction in the subacromial space. With bursitis, the bursa gets inflamed, it gets very thick, and it actually does the total opposite of what's meant to do. Instead of lubricating the area and restricting friction, it's keeping the area from moving the way it wants to, and it gets very irritated. Now, how do we fix that? A subacromial decompression. The decompression is twofold because we have 2 things to work on. the acromion and the bursa issue. So with the acromion, we'll do an acromioplasty. Acromioplasty means we will take either an RF wand or a burr or a rasp, and we will file down the undersurface of the acromion. That's because that will free up space in that subacromial area. Now, the other thing we could do is a bursectomy. That's also part of the subacromial decompression. A bursectomy is when we go into the subacromial space with a shaver that shaves out all that thick bursa, and then it sucks it right out of the subacromial space, so we've opened things up to stop and remove the impingement from the shoulder. Now last, I want to discuss instability. Instability, when we're talking instability, we're talking about dislocation and subluxation. Dislocation is when the humeral head comes fully out, dislocates, pulls away from the socket. Subluxation is when it comes partly out of the socket, but not fully, not all the way. Now the problem with subluxation or dislocation, and when it happens often, it can compromise the glenoid. As you remember from last week, we were discussing the glenoid and how it serves as the socket in the ball and socket joint. Now, if you're constantly dislocating and dislocating and dislocating, subluxating, you could be hurting the labrum that surrounds the glenoid. And if you tear this labrum, then you're going to only increase the amount of times that you're going to be subluxating or dislocating, because you're no longer going to have this labral rim to keep the humeral head in place. You see, the glenoid, it works as sort of a suction cup, but it only works like that if you have the labrum on it. So the glenoid is shaped sort of like a concave golf tee, but the labrum, it wraps around the glenoid, and it makes it more concave and forms sort of a bumper around the glenoid. And the humeral head fits right in there. So if we're constantly subluxating or dislocating, we're going to push away that labrum, and we're going to be left with a tear that needs to be repaired. Now where the tear is what dictates what it's called. I'll show you on my shoulder here. Imagine the glenoid here as sort of the face of a clock. If you have a tear from 2 o'clock to 5 o'clock, we call that a Bankart. B-A-N-K-A-R-T. Bankart, 2 to 5 o'clock. If it's on the posterior side, mirrored from 10 o'clock to 7 o'clock, that would be considered a posterior Bankart. Not nearly as common, but still, posterior Bankart, Bankart. Now, on top, if you have something from 10 to 2, then we call that a slap tear. SLAP is an acronym for superior labrum anterior posterior. Talking about 10 to 2. The superior, the top part of your labrum, has been torn and now needs to be fixed in order to replace that bumper around the glenoid. So that's sort of an idea of common problems in the shoulder: rotator cuff tears, impingement, and instability. I hope you enjoyed this. I'm really looking forward to next week's edition and learning a lot more. Thank you.